Okay, you guys can get started.
All right, wonderful. All right, as always, thank you to the Seattle Science Foundation for hosting us. It's always fun trying to come up with unique, interesting topics. This one we went with a little bit more bread and butter, but obviously an issue in all of our practices, and something that, over time we've tried to evolve different treatment strategies to direct skills in relation to minimizing this problem. But today we have three great articles. Two of our current fellows will be presenting them, Hiran Patel and Matt D'Ambrosio. We're very lucky to have him, both rock stars. And so they'll present three different articles on this topic, touching on different aspects of it. But just to highlight this issue, just a case to get started with. This is a 55-year-old female who presented in my office. She had a prior 5-1 T-lift done in 2017, and overall, looks pretty darn good. Maybe a little bit of a lack of lordosis at the 5-1 segment, but overall, I think we'd all be pretty happy with this X-ray. And then in a short time, 2 years later, comes back with this X-ray, and as you can see, we're now having some adjacent segment disease, some disc degeneration, maybe a little bit of instability at that 4-5 segment. So she gets an adjacent segment T-lift in 2019, and again, maybe we're not thrilled with her overall alignment from the 4-1 segment. Again, a pretty decent result here, and I think very quickly we start to realize this patient is probably a setup for one of our bigger concerns, adjacent segment disease. And so again, 4 short years later, this is her problem, and this is her at 3-4 with pretty significant disc collapse. Significant issue in relation to overall quality of life. And so again, this is a little bit of a different approach using a lateral-based surgery and reinstrumentation. But from 2017 to 2023, obviously, pretty drastic change. And I think all of us are trying to rack our brains in relation to how we treat this and how we try to minimize this problem overall. Obviously, with fusion constructs, it's hard to eliminate it in its entirety, but obviously our goal should be to help minimize this and provide our patients with the most amount of longevity in relation to their constructs. So with that, I'd like to turn it over to Dr. Patel, and he'll be going forward with our first article on this topic. Hiran?
Hey, good morning, everybody. All right, so I'll be starting off with this article. Be looking at indirect decompression and looking at indirect decompression and if it can reduce the rate of adjacent segment degeneration and reoperation after lumbar interbody fusion. So this was a systemic review meta-analysis, included 7 studies with a total of 576 patients. Primary outcome measures that they looked at comparing indirect decompression were rate of radiographic adjacent segment degeneration, the rate of symptomatic adjacent segment disease, and reoperation rate due to adjacent segment disease or degeneration after indirect and direct decompression. So just kind of some background on this and definitions that they used here for indirect and direct decompression. So in both groups of patients underwent interbody fusion. So for indirect decompression, that included A-lifts, lateral interbodies, and oblique lumbar interbodies. And for direct decompression, that included posterior interbody fusions or PLIFs and transforaminal lumbar interbody fusions or TLIFs. And the concept behind the two, so for direct decompression, of course, we're improving neurologic symptoms by directly removing compressive pathology on the neural elements. And then for indirect decompression, again, decreasing compression on the neural elements, but through things like restoring disc height and therefore increasing foraminal volume and increasing ligament ataxis, reducing spondylolisthesis and stabilizing any dynamic compression. And kind of the hypothesis or rationale behind this study and kind of the thoughts of why indirect decompression may have some advantages here is that, sorry, let's just go back to one slide. So with indirect decompression, there's less violation of the posterior structures and posterior tension band than with direct decompression. The thought being some of that may contribute to the development of adjacent segment disease, and also some advantages with indirect decompression in restoring or maintaining sagittal alignment, which is also an important factor for the development of adjacent segment pathology. So looking at this review, the articles were independently reviewed by 2 reviewers. Exclusion criteria, they excluded any studies or patients where interbody fusion was used for deformity correction. Also excluded any combined surgical approaches, for example, like a posterior lateral fusion with a PLIF. Excluded lower quality studies like case reports, reviews, and then other meta-analyses. So it's based in adults, so excluded any pediatric patients and also excluding any tumor or infection. So this table shows the articles that were included in this study. So there's just 7 articles, all retrospective studies. Sample size ranged from 48 to 142 patients. Mean age ranged from 48 to 71, so most were had an average age of about 40s to 50s, with one kind of outlier at 71. And the mean follow-up for these studies ranged from about 21 months to 60 months. Outcome measures in these, so most of these reported either reoperation rate or adjacent segment degeneration. There's one paper that also reported adjacent segment disease. This table here is showing some more characteristics of the 2 groups for indirect decompression and direct decompression. So we can see for indirect decompression, most of the techniques that were used were ALIFs. There's also one paper that reported ALIFs and lateral interbodies, and then one paper that reported OLIFs. And there was a mix of standalone ALIFs and then ALIFs augmented with posterior stabilization. Most of the posterior stabilization was percutaneous pedicle screws, and then the one paper that reported OLIFs had posterior stabilization with percutaneous cortical bone trajectory screws. And then for the direct decompression group, it was a mix of PLIFs and TLIFs, most of these having open posterior pedicle screws, one paper having percutaneous pedicle screws, and one paper having percutaneous cortical bone trajectory screws. So looking at the results of this for adjacent segment degeneration, the overall rates were 19.4% the indirect decompression group, 34% for the direct decompression group, with an odds ratio of 0.3, which was statistically significant, favoring indirect decompression. They also had some subgroup analysis. One of the subgroup analyses was standalone interbodies for indirect decompression compared with direct, and then also indirect decompression with posterior stabilization compared with direct decompression. And so for both of these, for the standalone, the odds ratio was 0.29, which was significant. And for indirect decompression with posterior stabilization, the odds ratio compared to direct decompression was 0.36. So again, in this subgroup analysis, both standalone and with posterior stabilization, indirect decompression did have an advantage over direct decompression for adjacent segment disease or degeneration. And then the other subgroup analysis divided direct decompression into PLIFs or TLIFs for comparison with indirect decompression. And for this, indirect decompression compared to direct decompression with a PLIF did show an advantage for indirect decompression with an odds ratio of 0.29. However, when indirect decompression was compared with TLIF, the odds ratio was 0.52, but it was not significant. So in this group analysis, it did show that the advantage for indirect decompression did go away when it was compared specifically with just TLIFs. Looking then at the rate of reoperation for adjacent segment, sorry, that's just a disease. For indirect decompression, it was 2.5%, and direct decompression, it was 6.1%. So And the odds ratio here, again, favoring indirect decompression at 0.4. And then the sagittal radiographic parameters, looking at segmental lordosis and total lumbar lordosis, both also favored indirect decompression. So had a mean difference of 1.8 degrees for indirect decompression and for segmental lordosis, and a mean difference of 7.1 degrees for total lumbar lordosis, favoring indirect decompression. Looking then at the limitations of this study, one potential limitation is different indications for direct versus indirect decompression. There are some indications for which indirect decompression may not be adequate, like bony stenosis or sequestered disc material. There's also a limited number of studies here, including this meta-analysis with 7, and also all retrospective studies. There are also a difference in follow-up periods between these studies, and adjacent segment degeneration, disease, and reoperation rates are all going to be time dependent. So difference in follow-up can lead to different rates of reporting there. And then also looking specifically at adjacent segment disease, only one of these studies here reported adjacent segment disease.
Hey, Kieran. Oh, go ahead, man.
Oh, sorry. No, I was just going to say summary and key points. So adjacent segment degeneration is lower with indirect decompression compared with direct. Reoperation rate is also lower. Some things that may play a role, we don't necessarily have a causative evidence for, but could play a role, are preservation of the posterior elements and also sagittal alignment.
No, I think that's a great review of the article here. Obviously, there's limitations of this data as far as the meta-analysis, the quality of the studies that go into it. But I think it's attempting to try to ask some important questions and maybe gives us some broad stroke interpretations, maybe not some granular practice changing details here, but suggest that there may be some advantages here to indirect decompression as it relates to adjacent level disease. Why I love adjacent level disease, why we all love spine, is because we don't know all the answers yet, right? And we're still just trying to optimize these procedures for these patients to give them the best outcome. My question I'd love to pose for some of the other faculty on here, either Dr. Blumenthal or Dr. Schoof. This paper obviously makes some suggestions. Is it the laminectomy? Is it just the introduction of pedicle screws? Is it the technique of pedicle screw placement? Is it the realignment or lack thereof? In your minds, how are you thinking about adjacent level disease? What do you think are the major causative factors, in your practices?
Good summary. There's no question that adjacent segment disease is multifactorial, with some of it being uncontrollable, probably being genetics. But I think this study shows or seems to indicate or points us in the direction of a better sagittal realignment, which we all know we can get with anterior interbody fusions, whether you do perc screws in the back or not. And then the addition of posterior decompression, and potential, not clinical destabilization, but subclinical, is just another factor in adjacent segment progression. But I think it's the realignment. You just can't get as good a realignment and sagittal parameters and balance with a TLIF or a PLIF. You just can't. Whereas we know that we can with anterior, better than probably lateral, but lateral probably better than TLIF. So I think that's at least one of the factors. And I think you pointed that out well.
Scott, I'd be curious to know, how your practice has evolved, maybe say, over the last decade or 2 decades in relation to, say, for instance, we could debate the merits about fusion in the setting of degenerative spondylolisthesis, but say we have a mobile 4-5 degenerative spondylolisthesis that warrants a fusion surgery. What has kind of changed in your practice over the last period of say 10 years where, you're originally doing this and now you've gone more in this direction?
I think that the biggest change is if a patient had a degenerative spondy with stenosis, we would do decompression. I think now we've got enough data that restoring disc height and reducing the spondy anteriorly results in enough indirect decompression that you don't need to do that. The other thing, if you hadn't led me down the spondy path, just for the third re-op, the L3-4 level, which was just a degenerative disc without instability, we'd put an artificial disc there, assuming they're not 70 years old, but if the patient was still, of that age, and that might stop the cascade going higher, who knows, by preserving motion.
And then maybe one last question. When we're thinking about, and obviously this article mentioned standalone interbodies, to what degree do you feel comfortable doing a standalone for a degenerative spondy in the setting of whether it's instability or grade or those kind of things? What factors do you look at to say, yeah, I feel confident in a standalone device versus supplementing with posterior fixation?
Yeah, so I'll tell you that in the face of no instability, just degeneration, standalone, we're completely confident with that. When it's a kind of a mobile spondy that moves, maybe more than 3 millimeters on flexion extension, I think most of the guys at TBI would back that up with perk screws. Just whether it's belt and suspenders, but certainly it's a low morbidity thing, and it makes you feel better, sleep better at night, knowing you've got that extra bit of fixation while your biologic fusion heals.
Hey, Scott, to follow up that comment, because I think that's such a great point. But I would ask, are there any patient factors that you may consider, osteoporosis, obesity, that may deviate your course from what otherwise might be a good standalone candidate, or do you think that the fixation is adequate, no matter what?
So we argue about this all the time. When we look back at some of our standalone ALIFs, osteoporosis does make a difference. Obesity, it turns out, really doesn't. And then one of the other things that we thought would make a difference is like job demand, like a work comp patient that wants to go back to a heavy job. Well, if you wait for them to heal, which you can get them to heal anteriorly alone, that didn't make a difference either. But we've started, really lowering our threshold for doing DEXA scans on these patients, and if indeed they're well into osteopenia, closing in on osteoporosis, we would just plan to back those up every time.
That's great. We have one question in the chat box about hooks at the level above a fusion for ASD, and this is a point that sometimes is discussed in relation to PJK. I think in the degenerative setting, thinking in regards to a soft landing or something along those lines, I think it'd be very unlikely that someone would use hooks or disrupt a native segment above the level of the fusion. As Scott mentioned, degenerative disease above potential disc replacement is a point of conversation, but I think hooks above a level of a degenerative segment that is fused, I think is something that probably, at least to my knowledge, is not utilized frequently.
Yeah, I would piggyback on that as well. I mean, obviously the goal of the hook there is to totally avoid the cephalad, unfused facet joint by just getting some attachment to the to either, if it's a laminar hook or a TP hook, and obviously I just think our generation in general are just, especially as adult surgeons, we're just not as savvy with employing hooks. Obviously our pediatric colleagues still very routinely will utilize them. I've used hooks here and there in adult degenerative spine, and in my not long experience, I've had some difficulties with fixation, things like that. So I think the role for a potential hook in, let's say, a degenerative fusion, in my mind, would be very robust anterior column support, with large interbody fixation, and then maybe it's an in-betweener as far as is it a standalone or a standalone plus, where you can get away with some decreased fixation posteriorly while really trying to avoid violating that facet joint that we try to protect, that we know just plays a role in contributing to adjacent level disease if you got a screw going right through the adjacent facet. So, but I think it's food for thought. I don't think it's well studied in adults. So I don't know. Scott, do you have anything to weigh in? Are you using hooks at all in your adult practice?
I'm going to punt on that one. That's not part of my thing.
Yeah.
Yeah, that's and I think, Matt, if you don't mind taking control, I think the prior comment we made about restoration of segmental lordosis is key, and hopefully our second article touches on that. Just before we get started, we have one other quick question. The role of decompression alone or posterior lateral fusion only cases for degeneration without instability. I think it's a good question. I think most of us would likely lean towards an isolated decompression in that setting. I think the indications for fusion in the absence of instability are probably few and far between. And even sometimes in the setting of a degenerative spondylolisthesis without instability, we're still talking about isolated decompression. So I think a reasonable conversation point, but for that patient, we might be more leaning in the direction of an isolated decompression.
Okay, I'm going to get started. My article is titled L3-4 hyperlordosis and decreased lower lumbar lordosis following short segment L4-5 lumbar fusion. Is associated with the L3-4 revision surgery for adjacent segment stenosis. It's out of the Global Spine Journal in 2023, and it's a retrospective review of their pre-existing prospective cohort out of the London Health Sciences Centre in Ontario, Canada. So purpose of the study, compare the preoperative and post-op change in the L4-S1 lordosis after L4-5 or L4 to S1 fusion in a cohort of patients with and without revision surgery for post-fusion adjacent segment level spinal stenosis. The reason they did this study is because the most frequent location of an index lumbar fusion is L4-5. The rate of revision after lumbar fusion in the literature can be between 10 and 20%. And the number one reason for these revisions is adjacent segment disease, with the most common segment being the L3-4 levels after an L4-5 fusion. (212 patients surgically treated for spinal stenosis between 2006 2012, identified from prospective database of patients with degenerative lumbar spinal stenosis refractory to at least 3 months of non-operative care. All the patients who had that index decompression surgery with posterior lumbar interbody fusion or posterior lateral fusion at the levels of L4-5 or L4-S1 were included. Patients were then followed for 10 years and retrospectively evaluated if they underwent revision or not. So some of the reasons for the revision were claudication symptoms or radiculopathy symptoms. Main purpose of the study was to compare patients with revision to patients with no revision. And while the type of revision surgery was not part of the primary outcome, they did mention that revision surgery could include decompression with laminectomy and or discectomy with or without a fusion extension at that L3-4 level. Post-op radiographs were taken at post-op day 0 and first follow-up appointment, which varied between 6 and 12 weeks. And they took a number of measurements of their patients throughout the study. They looked at global lumbar lordosis, which is our well-established lumbar lordosis. Then they looked at a number of sagittal alignment parameters, such as pelvic incidence, pelvic tilt, sacral slope, and the PILL. They also measured the lower lumbar lordosis angle, which they labeled LLL, and upper lumbar lordosis angle, which again they labeled ULL. And then more importantly, they did a focal lordosis at the L3-4 level to assess the change there. And then they looked at a lordosis distribution index. The lordosis distribution index is a ratio of the lower lumbar lordosis compared to the global lumbar lordosis. And they used basically the parameters set by Barry et al. To organize that into either normal LDI, hypolordotic, or hyperlordotic, being 50 to 80% was that middle range there. So of the 212 initial patients undergoing the L5-1 or L4-1 fusion, 104 of them met the inclusion criteria, and then 19 of those were included in the revision portion of the study. Baseline characteristics, clinical characteristics, and pre-op patient-reported outcomes were similar between the no revision and revision groups. And the only real difference was that the revision cohort trended toward including more females and more comorbidities, which not that surprising. There were no statistically significant differences in operative details for the index procedure between the revision and no revision groups. However, there were some noteworthy characteristics found in the subsets. 76.5% had an interbody fusion in the no revision group, and 68% had an interbody fusion in the revision group. And then the majority of the patients in both groups had an interbody cage placed at the L4-5 level and had a single level fusion. No statistically significant difference was noted between the sagittal parameters, the pelvic tilt, PILL, or the upper lumbar lordosis. And then the no revision cohort did have a greater pre-op global lumbar lordosis and lower lumbar lordosis than the revision group. So more lordosis in those lower segments and the lumbar spine overall. There was a significant further decrease in lumbar or lower lumbar lordosis for the revision group relative to the no revision group. So in other words, the group that ended up needing a revision was fused in a more hypolordotic position. After fusion surgery, the GLL or global lumbar lordosis and LLL remained lower in the revision group compared to the no revision group. And then the L3-4 focal lumbar lordosis significantly increased in the revision group compared to the no revision group. After fusion surgery, the global lumbar lordosis remained lower in the revision group compared to the no revision group. And the proportion of patients in the revision group who had a decrease in the lower lumbar lordosis was significantly higher than the proportion of patients with this change in the no revision group. You can see that here. The last parameter that ended up being significant was that the proportion of patients in the revision group who had a decrease in the lower lumbar lordosis and concurrent increase in L3-4 focal lumbar lordosis was significantly higher than the proportion of patients with this change in the no revision group. That's a lot of kind of jumbled information in the form of a chart. So to clarify that, and I think this was a great part of the study, they kind of included an example to translate those charts into a case example. This is an example of adjacent segment disease when patients are fused in a hypolordotic position. Figure A on the left is before the initial L4-5 fusion, with the lower lumbar lordosis drawn as the dashed line, the L3-4 focal lumbar lordosis drawn as the solid line. The middle figure is the radiograph of the same patient after that L4-5 fusion. You can see the LLL has been decreased from 38 to 32 degrees, and the FLL is then increased from 10 to 14 degrees. So now the L3-4 segment is now in a hyperlordotic position. Figure C then shows the emergence of the adjacent segment disease at that L3-4 level 6 years later. So key points of the study. The purpose of the study is to back up their original hypothesis while investigating this paper, which is that the hypolordotic fusions at the L4-5 level lead to increased shear forces at the L3-4 level. Therefore, decreasing lordosis at L4-S1 during fusion surgery may lead to an increased risk of revision surgery at the L3-4 level. So Overall, I believe it's an adequate study for this very specific topic, but there are some significant limitations to its study design and overall methods. One limitation is that this is a retrospective study of a previously prospective cohort of a small sample size. This inherently increases the risk of selection bias. Also, being a retrospective study, they were at the mercy of each individual surgeon's follow-up protocol, and x-rays were not taken at specific time points. Instead, they were generally taken at post-op day 0, then their first post-op appointment, which varied based on the attendings. It's likely that there may be some patients in the 85 patients that did not require revision surgery, in fact, did have adjacent segment disease, but were actually asymptomatic because they were not getting regular films. In addition, the type of x-rays that were taken were only lumbar spine x-rays, so global measurements could not be adequately obtained. And other studies have shown that global sagittal alignment, for example, can contribute to ASD. The inclusion criteria for the study included the diagnosis of spinal stenosis and did not delineate really any other diagnoses, such as those related to instability, which may have an effect on the shear stresses that ultimately end up on L3-4. And then the final limitation of the study really came down to technique. Procedures included in the study were all posteriorly based procedures. And the authors note that the limitation in obtaining lordosis with the smaller lordotic angle found in many posterior implants, they did attempt to mitigate this by using the largest interbody implants they could fit and by placing the interbody device as far anterior as possible. But it is still a posterior implant. We know that you cannot get as much lordosis that way. Thank you.
Matt, really nice job. Great summary of the article and touching on the highlights as well as the limitations of the study. You're going to be out in practice in a few short months. It's going to come up on you quickly. Is there anything from this article that you glean that may influence what you do when you start or moving forward in relation to some of these common problems?
I think the biggest thing I took from this article is to be as critical as possible of what you're doing after you do the surgery. So if you're doing an L4-5 or L5-1 fusion, be as critical as possible of the films preoperatively and postoperatively and take the measurements.
So from a preoperative standpoint, does it change any planning that you may have going into the case? Does it change anything that you might do otherwise?
It would certainly lead me toward moving toward a more laterally or anteriorly based procedure to get more lordosis.
Right. And I think that's key. And I think oftentimes, I'm certainly guilty of it because we see a 4-5 degen spondy, or we're thinking we're doing a 1-level fusion in isolation, and maybe we aren't as critical of the overall alignment as we should be. And then the problem is we end up in this cascade, and next thing you know, someone's fused 4-1 and they're fused flat, and we're looking at, significant problems that we've created, right? This whole issue with iatrogenic flat back. And so I think we have to be critical of the fact that whenever we're fusing a patient, we have to be cognizant of their overall alignment, and that, and I know in my practice, I get EOS films on pretty much all of my fusion patients now, just so that I can understand their overall alignment and what's going on. And I think hopefully that lends itself a little bit better to restoring some of that segmental lordosis at those lower levels. Amrit, from your perspective, this article and in your own practice, have you seen similar findings, whether it's with, maybe not achieving the parameters that you wanted with that first surgery and maybe more expeditious adjacent segment disease?
Yeah, I mean, I think why this article rings true is, it's not the most highly powered article, right? And the cohort's kind of small, but I think that the value of this article is it's 10 plus year follow-up, which I think those are the timelines we need to be looking at to really better understand, adjacent level disease and adjacent level failures. I think that we all have some iatrogenic flat backs in our practices, even if we fastidiously try to follow the rules of lumbar lordosis and realignment. In my practice, it's what do you do with the patient who has severe critical L4 to S1 stenosis, that with unstable spondies, who's morbidly obese and is having a progressive foot drop or a progressive neurologic disorder. That's where I've kind of run into my own problems, because I'm admittedly not a big T lifter, but I'll fit the tool to the job at hand sometimes. And that's the patient that every once in a while, every couple of years, creeps up on me, and we say, well, we got to do, we can't just say, hey, go lose weight and kick sand. We have a progressive neurologic deficit. What do you do? Well, Dave, you and I know we have great access surgeons at Penn. We're very lucky. So we're a big anterior column institution, but sometimes there's patients I feel bad sending to our access surgeons for an eval, especially when it's an urgent matter. So yeah, and what do you do with that patient? I've done a 4-to-1 Lamy TLIF on them. Try to do your best to realign them. Do you take down bilateral facet joints to really optimize the lordosis of the TLIF? Then you really got to do a good disc prep to make sure you get that anterior column fusion. And you're doing this in a very deep hole. So yeah, I think if any surgeon is going to look honestly and introspectively at their practice, yeah, we've all created some flat back deformities, I think, here and there. I think we just need to be mindful of mitigating that as much as we can. And in my practice, that's through ALIF and lateral. It's through, bony shortening osteotomies posteriorly when appropriate. But yeah, I think there's still some patients that are just, difficult to realign, and maybe we do accept suboptimal, alignments just in the effort to urgently, treat a patient. So I don't know. I think that brings up a good point to bring up to the rest of the panel here. Dr. Blumenthal, I see Dr. Abdul-Jabbar is on here. What do you do with that tough patient? They have that kind of staircase L4 to S1 spondy. Everything looks pretty good, cephalad. What do you do? Do you maybe it's a more urgent matter. What's your full court press in that patient population?
Yeah, pretty much. I agree with you that the only time that I would ever consider doing posterior like a TLIF would be if there are contraindications to anterior approach, like a more hugely obese patient. What's interesting is that there's obviously, and we're talking about it, ramifications to fusion. And I think as I'm sitting there listening, I was trying to figure out why all these devices are being developed that are motion preserving, like Limiflex and Coflex and things like that. And it's because we can't always get what we want with a static implant like a fusion, particularly like you said in the setting that you described. Will there be a place for these dynamic devices? They really haven't found their sweet spot yet, but certainly they keep coming back. And obviously the Denesis came and went, but now we've got Limiflex and the TOPS device and Coflex. So there might be a place to these dynamic devices. I don't know.
You guys need to develop the lumbar laminoplasty, right?
Exactly.
That's great commentary. Anyone in the SSF conference room, any comments on preoperative workup from these one-level degen spondies in relation to whether it's overall alignment, or is there anything that you do in particular to respect, patients' parameters or things like that?
Well, same like you. Having an EOS in the office now is a game changer to be able to preoperatively. We're doing EOSs now. I don't know if that's the correct term. We are doing an EOS scan on all our lumbar arthroplasties to try to get some normative data on if we're doing patients the right thing in terms of their balance post-op, because we have limited, obviously, lordotic angles we can use with arthroplasties. So we're trying to get some data with that as well. So yeah, definitely pre-op standing EOS.
Hey guys, this is Amir.
Flexion extension, MRIs, CT scans, all three, and as everything's been mentioned before, looking at Hounsfield units on the CT scan for end plates. and then flexion extension to look at mobility. But Dr. Chapman's a big believer in Coflex, and as you mentioned, so we do a fair bit of that as well, just to kind of preserve motion. We look at foramens as well, just to look at the superior articular process, kind of impinging the foramen sometimes, and using Coflex to get that opened up a little bit more. So, yeah. Yeah, I would like to know your thoughts on EOS. We don't have one, and how has that been helpful in your practice, and how do you get it approved for patients in terms of insurance and all that?
Yeah, it's a good question, Amir. We haven't had an issue in relation to insurance approval related to scoliosis X-ray. And again, I do it for pretty much all my fusion constructs. It really helps seeing their SVA often on that lateral film. I think, sometimes it's cost prohibitive just because the unit itself is so expensive. We justify it based on, some of these deformity patients requiring, X-rays for the next 10 years, and the reduction in radiation in addition to the data it gives you, I think is very justifiable, but it is a significant expense. And I think sometimes hospital systems may be a little resistant to that, because I think on the back end, it probably doesn't provide as much reimbursement as the initial upfront cost justifies. Scott,
Yeah,
I don't know if you've had a different experience, or Amrit, if.
No, it's fine.
No, I mean, we just bill it as part of just our regular X-rays in the office. But you're right, the initial capital expense in some settings is prohibitive.
Yeah, I was just going to echo that.
Do you think the inclusion of hip joint and then hip arthroplasties, et cetera, has changed how much correction you do, especially if the hip's fully extended and you don't want to extend more, if you're giving patient more lordosis, et cetera? Do you look into that at all?
I think it's been very helpful with assessing whether it's limb length discrepancy, pelvic obliquity, as you said, hip replacements. We can see the version of the hip replacements on the imaging. I think there's a lot of factors that really have allowed us to be a little bit more critical in relation to what we're doing. So yeah, I agree with you. From that perspective, it's really helpful in seeing the version of the hip replacements if they've had arthroplasty prior.
Yeah,
Just wanted to
I
make
think.
one comment.
Oh, sorry. Go ahead, Amir.
Yeah, this is Amir Abdul-Jabbar. I know you guys were mentioning anterior column, and we kind of have the opposite here, where I love doing ALIF and lateral, but we do have pretty limited access to access surgeons. So I know in our practice in Jens as well, we do a lot of T-lifts out of necessity. Like you mentioned, you may not have the opportunity to optimize the patient. They've got an acute neurologic deficit. And we've found pretty good results with, as you mentioned, the bilateral facetectomy, I think is really important, but also adding in expandable cages if you do need to get that extra lordosis. We found that we can get, 15 degrees improvement if you are doing that kind of what we call an intradiscal osteotomy. So it does take a lot of extra time, but in that case where, you're worried about fusing someone flat, there are some tools there to get that additional lordosis that may prevent them another surgery down the road.
Amir, when you're using the expandable cage, do you use them bilaterally and get them on the apophyseal ring? Do you kind of put one in unilaterally and try and get it all the way anterior? What's your technique from that perspective?
I do. If I'm not as worried about the alignment, I'll tend to use just a static banana cage, try to get it anteriorly, and use the same IDEO technique, because you can really, compress the posterior column and get some good lordosis there. But especially like in 5-1 that's really collapsed, especially like a bigger male patient, can be very challenging to get that height back. And if I am going to do expandables, I'll do bilateral, really get it onto that apophyseal ring and try to lift it up. And it's a very powerful tool.
Yeah, I second that. I find that, oftentimes in the setting of expandable cages, if they're put in the middle of the disc space, the subsidence rate is incredibly high. So, as very well mentioned, if you use the bilateral technique of getting them on that apophyseal ring, oftentimes it seems like the rate of subsidence is significantly less, and you can be more powerful with that correction. Kieran, do you mind leading us into our third and final article?
Yeah, of course. I think I just need to go on to the next slide here. All right, so going on to the next article then. So this was another review and meta-analysis looking at patients who developed adjacent segment disease and trying to identify what demographic, clinical, or operative risk factors predisposed patients or led to the development of that ASD. So it included 35 studies with a total of 7,374 patients. And then this is just a table showing the inclusion and exclusion criteria for this. So for inclusion criteria, studies that reported clinical and demographic risk factors for ASD, excluded patients with any preoperative diagnosis of ASD or any prior thoracolumbar surgery, also excluded any surgery for trauma, infection, malignancy, or any congenital disorders. And also excluded papers that only reported incidence of ASD or ASD as a complication, but not any clinical or demographic factors that could be used in the meta-analysis. So data here, there were 34 retrospective studies, 1 prospective study for a total of over 7,000 patients. The incidence of ASD in these studies ranged from 2.6% to 62%, with a total or mean of 17.2%. The follow-up period was a minimum of 12 months and had a mean of 165 months. And then for the meta-analysis, the possible risk factors that they analyzed were age, gender, BMI, smoking status, diabetes, hypertension, a diagnosis of osteoporosis, bone mineral density is measured by the T-score, preoperative JOA score, a floating fusion or a fusion that included the sacrum distally, if there's a violation of the superior facet joint, if there's a decompression outside of the fusion construct, and then they also compared posterior lateral fusion to a PLIF with T-lifts, single level or versus multi-level procedures, and then also intraoperative blood loss and operative time. So looking at the results here looked at either odds ratio or mean difference, and they found that the demographic or clinical factors that they did not find a significant difference for were all of these on the left. But there were 4 that there was a statistically significant difference in the odd ratio or the mean difference. That was BMI. So patients with a higher BMI were more likely to develop adjacent segment disease. Also, patients that did not have a fusion, so floating fusion versus distal fusion. Floating fusions, so not fused to the sacrum, had a higher rate of adjacent segment disease. Violating the superior facet also had a higher rate of adjacent segment disease. And then patients that had a decompression outside the fusion construct also had a higher odds ratio of having adjacent segment disease. These are just kind of the forest plots showing that. You can see here, BMI, higher BMI had a higher mean difference for adjacent segment disease. For smoking, diabetes, and hypertension, we can see there are trends, but statistically not significant for an odds ratio of adjacent segment disease. Similarly here, osteoporosis, T-score for bone mineral density, and preoperative JOA score, no statistical significant difference for ASD. And then here, for all three of these, whether or not the fusion included the sacrum, violation of the superior facet, and if there was a decompression outside of the fusion construct. So all of these had a greater odds ratio for the development of ASD. So looking at limitations of this study, just some general limitations of common in meta-analyses were some heterogeneity in the data that was used. So there was heterogeneity in pre-op diagnosis, number of levels fused, location of the fusion in the lumbar spine, and also in the criteria used to define ASD. But overall, I think a well-conducted meta-analysis just with limitations in what data was available in the published literature. So then kind of just some summary and key points that in this meta-analysis, the overall rate of ASD was 17%. Of all of the clinical and demographic factors that they looked at, they found 4 significant risk factors for developing ASD. So higher BMI, fusion that didn't include the sacrum, violation of the superior facet joint, and then a decompression outside the fusion construct. So like interesting findings here, and I think definitely useful, but also kind of leads into thought of how we can use this data to kind of decrease the rate of ASD. If we can really optimize BMI, I think fusing down to the sacrum, you in one way take away having like a distal adjacent segment disease, but is fusing more levels necessarily beneficial there? So I mean, interesting things to think about with this paper.
Aaron, I agree, and I think this paper is a good kind of overall summary of kind of the topic that we've been discussing this morning, and I think you did a really nice job summarizing this. Again, these meta-analysis are trying to understand or at least point us in the right direction as far as the multitude of factors that are likely contributed to adjacent level disease. I think that your top bullet point there is valuable because talking about boots hit the ground, tires on the road, like what are you actually going to talk to your patients about? Because I think bringing up adjacent level disease when you talk about a fusion is important, and I do it with every single patient I'm talking about, talking with in the office, as you've seen. What number are you going to cite them? And is a lumbar fusion a lumbar fusion a lumbar fusion? I would say no. And then I guess my question for you, Hiren, as about to be out in practice, kind of similar to what was posed with Matt, with those 4 bottom bullet points, yeah, optimizing BMI is great. How do you avoid the rest? So you have a 4-5 unstable degen spondy with a patient with neurogenic claudication and critical but stable L3-4 stenosis. And let's say L5S1 stenosis too. How about that? What are you doing for that patient? And asterisk, no one knows the right answer, but what are you thinking about now, kind of based off this article and kind of the discussions from this morning?
So similar issues like you mentioned before, BMI, really kind of hard to optimize that, especially in a reasonable time frame with a patient who has progressive neurologic deficit. So in terms of actually lowering BMI, I don't think there's necessarily a lot that can be done, but at least trying to optimize nutrition in the pre-op and peri and post-operative periods. I think in kind of the situation you mentioned, I would want to do an ALIF just because a lot of things that Matt mentioned as well, getting good sagittal alignment, not violating facets as much as possible or posterior elements. I think a 2-level ALIF in that situation would be my ideal. But again, like you said, a lot of difficult considerations with that.
Yeah, and I think you hit the nail on the head. The difficult considerations are you taking a level that you wouldn't normally fuse and now subjecting it to a fusion because it's adjacent to a level that needs to be fused, but you need some type of decompression there. And so, that's the question that we don't have the answer to. Dave, what are you doing these days in your practice as far as like one of those tough clinical situations that's pushing you towards a floating fusion? Where do you draw the line, and kind of what are some of the considerations you're thinking about?
Yeah, I still do, in that instance where they have critical stenosis, I will do a decompression above a fusion construct with the understanding, as you said, that a lot of preoperative education can help avoid difficult conversations afterwards if they develop ASD. I don't know if that's the right or wrong answer. Obviously the use of Coflex, like Amir mentioned, and Dr. Chapman's a big fan of, I think maybe can minimize some of that. I think Dr. Blumenthal's comment about, you fuse the level that is unstable and then a disc replacement is certainly a reasonable line of conversation. In my hands, I practice a little bit more traditionally from that aspect and am probably fusing the unstable segment and decompressing above. I do worry about doing a fusion and then decompressing below in the lumbar spine. I think that's a setup for a problem. I think as you very astutely mentioned, we don't have the right answer for this. And I think a lot of it has to do with making sure that your patients are educated on the pluses and minuses to a lot of different treatment modalities.
Scott, is that a situation where you'd employ Coflex?
Yeah, I'm much like Jens. I'm kind of a big fan of Coflex. I think, as we talked about earlier, doing a fusion does, obviously everything's risk reward, and it does create some problems as well as obviously correct some problems. I think Amir brought up, and probably for the general audience as well, not all of us are as lucky to have great access that we can get all the time. So posterior procedures are still obviously the most commonly done procedures. One of the other, I think was a question earlier, spoke about, or Dave spoke about the fact that, if it's a stable, less than grade 1 spondy and the primary symptoms are stenosis, just doing a decompression alone may be sufficient as well. And then the other thing that we didn't mention is, for those of us that are lucky enough to have good access, thinking about the future, because if you do an anterior and someone young enough that they're going to have adjacent segment, it's difficult to do repeat anterior retroperitoneal surgery, particularly above 5.1, if you've already done something above 5.1. So again, that's another consideration, maybe against anterior surgery in a younger person who you may be back at some point. So all these things have to be taken into consideration.
Yeah, I agree. I think that's very well put. One last question from the chat. Should we treat radiologic evident but not clinically symptomatic adjacent level disease? I don't. If they're not having symptoms, especially if we're not at a cord level area or conus level, I will very routinely just watch adjacent level disease before it, hopefully never becomes adjacent level failure. So I don't go chasing after the radiographs there, but I think it's a great question. I think, obviously there's a exception to every rule here. I don't think there's one right answer.
Neil Patel again at SSF. We do a midline sparing approach, and I think that we think that prevents some of the ASD as well. And then it's really nice when we get a referral and the spinous process at the level of the fusion is preserved, just the top aspect of the spinous process, so that we can put an interlaminar device. And sometimes those patients aren't candidates because the whole spinous process was taken. So it's really nice to kind of have that preserved. So I've really kind of picked that up with Dr. Chapman. Definitely do that in my practice.
That's a great point. And I think we'll probably close with that as we're running short on time here. And so on behalf of myself and Dave Casper and our great fellows, Hiran and Matt, we at Penn Medicine want to thank you for having us here and for the lively conversation. It's always a pleasure.
Thanks, everyone.
Great job. Have a great weekend.
Wake up, man. Wake up, man. So, quick announcements for the robotics course. No, please. Next. I'll be using a palette. Which one do you want me to dress up as? Stronger. I'll let you I have a message here. It is.
And with Polly on top of that.